My name is E.Garrett, and this is my Systems Regions Assessment for Nursing 305, the physical assessment, and my instructor is Dr. Oden, and this is my patient, Kristen. We're going to start with the eye assessment, and first thing that we're going to check is measure her visual acuity. And we're going to do that by using the Snelling chart. And I'm going to give my patient a gauze and have her cover her right eye. And we're about 20 feet from the Snelling chart. And I'm going to ask her to read the smallest line that she can see.
LFED.
Okay. And then I'm going to have her cover the other eye and have her read the next line below that one.
LFED. CEF.
Okay, so measuring her visual acuity from this distance, and then I will take the distance that she is from the chart and the smallest line that she can read, and that will give me the measurement of her visual acuity. The next one that we're going to check is her near vision, and I'm going to give her a Rosenbaum Pocket Vision screener, and I'm going to have her hold it at a comfortable distance, about 14 inches from her. Hold it up for me. And then have her read the smallest line.
YOURDOREA.
Next we're going to measure Kristen's peripheral vision, and we're going to measure that using the confrontation test. I'm going to stand opposite of my patient and have her cover her right eye, and I'm going to cover the opposite eye, and then I'm going to hold my fingers out of vision, and when I bring them in, Kristen's going to tell me when she can see the top of my fingers.
I can see them.
Okay, and then we're going to try them just a little bit higher.
I can see them.
And then just a little bit lower.
I can see them.
Okay. And that checks her peripheral vision. Coarse eyebrows would indicate hypothyroidism. And we're also going to notice if her eyebrows are thin, and if they were, we would ask first, does she pluck or does she trim? And then if not, that could also be a symptom of hypothyroidism. Next, we're going to inspect the orbital area, and we're looking for edema, redundant tissue, or lesions. Edema would indicate thyroid disease, allergies, or renal disease. Redundant tissue below the orbit may be loss of elasticity of the tissue with the aging. And also lesions, they would be yellow tinted lesions on the periorbital tissue, and that would represent deposits of lipids, and that may suggest abnormality of lipid metabolism. These lesions are elevated plaque of cholesterol, and they're most commonly noted in the nasal portion of the upper and lower lid. Next, we're going to inspect the eyelids, and first we're going to check her ability to open and close her eyes completely. If eyes don't meet completely, the cornea can become dry. Next, we're going to palpate the eyelids, and we're palpating for nodules. And we're also going to assess if there's pain on palpation. Do you have pain on palpation now? Okay. Pain on palpation is consistent with scleritis, orbital cellulitis, and cavernous sinus thrombosis. An eye that feels firm and resistant to palpation may indicate glaucoma or a retrobulbar tumor. Next, we're going to pull down the lower lid and inspect the conjunctiva. There we go. Okay, we will pull down the lower lid and inspect the conjunctiva in each eye, and we're inspecting the color. We're looking for erythema, which may indicate allergy or conjunctivitis. And bright red blood would suggest subconjunctival hemorrhage. We're also checking for discharge and for lacrimal gland punctua. Now we're going to inspect Kristen's eyes, the internal eyes, for corneal clarity. And, hers is clear, which is what you would expect. There should be no blood vessels because the eyes are avascular. Also, we're going to check for cornea sensitivity, and this is checking the cranial nerve number 5. And we're going to do that by having Kristen look up, and we're going to do the swab test, cotton swab test. So as Kristen look up, I'm going to wipe gently across, and the blinking sensation is reaction is what we're looking for. Now we're going to evaluate Kristen's pupils, and her pupils should be round, regular, and equal in size, and they are. And next we're going to check how her pupils constrict and dilate, and we're using the ophthalmoscope. And so when I pass the light over Kristen, look straight ahead for me, look right up here. We're going to do the swinging flashlight test. We're using the ophthalmoscope. And as I pass the light over her pupil on the left and over the right, when the lights shine, they should constrict, and hers does. Okay, pause it.
Okay.
Okay, next we're also going to test Kristen's pupils for constriction to accommodation. And I'm going to take my pen and hold it about 10 centimeters from the bridge of her nose. And while she's looking at the pen at a distance, and I move it slowly to her face, then her eyes should go from dilatation to constriction. And hers does. A failure to respond to direct light but restrained constriction during accommodation is sometimes seen in patients with diabetes and syphilis. I'm palpating the lacrimal glands in the inner canthus of her eye, and the lacrimal gland is rarely enlarged but may become so with tumors, lymphoid infiltration, sore cord disease, or Sojourn syndrome. Next we're going to evaluate muscle balance and movement of the eye, and we are checking for cranial nerves 3, 4, and 6, and the 6 extraocular muscles. And I'm going to do so by holding Kristen's chin to prevent her from moving, and I'm going to ask Kristen to watch my finger as I move it in the 6 field gauge. By looking extremely lateral, you may notice some rhythmic movements of the eye, which is nystagmus. The idiopacity in the path of the light will stand out as black density. Absence of red reflex is often of improperly positioned scope, but also may indicate total opacity of the pupil by cataract or hemorrhage into the vitreous humerus. Next, we're going to inspect the ears. First, we're going to inspect the auricle and the mastoid area. We're checking her ears for size and symmetry, and we're also checking for landmarks and any color. The ears should be the same color as the facial area and the neck. And we're also checking for the position of the ears, and we're checking from like the top of the ears to the tip of the nose. And then we're checking for any deformities or lesions, and Kristen doesn't have any. Also, we're going to inspect the external auditory canal for discharge and color. And she has no discharge or color. We're also going to palpate the auricles and the mastoid areas for tenderness, and tenderness may indicate mastoiditis, swelling, or nodules. Also, we're going to inspect the auditory canal with the otoscope and note the following. We're looking for serum, and if there's serum, we're going to note the color of the serum. And also, we're looking for lesions or any type of discharge. I'm also inspecting for the tympanic membrane. And a normal tympanic membrane should be shiny gray in color. No movement is expected when the tympanic membrane is perforated. Also, we're going to assess Kristen's hearing. And we're going to do that through, to check the cranial nerve 8. First we're going to do, what I'm going to ask Kristen to do is to repeat something that I tell her. So I'm going to have her put a finger in the ear, and then I'm going to move beside Kristen, and then I'm going to say something in a soft voice to see if Kristen can hear me. The weather is cold.
The weather is cold.
Without being in eye view of Kristen, and by her repeating what I said, that lets me know that she can hear when I whisper. The next we're going to do is, the next two tests we're going to do are called the Weber and Wren test. And first with the Wren test, we're going to use the tuning fork. And I'm going to cause the tuning fork to vibrate and place it behind on Kristen's mastoid bone and begin to time, and she's going to tell us when she can no longer feel the vibrations.
Okay.
And with the fork still vibrating, I'm going to hold it next to Kristen's ear without touching her, and she's going to listen for the sound and let us know when she can no longer hear it.
I can't hear it.
Okay, and she can no longer hear it. The time between the bone conduction and the air conduction is usually 15 seconds. Air conduction sound should be heard twice as long as bone conduction. Next, the Weber test, also using the tuning fork. We're going to place the vibrating fork in the middle of the patient's head, and we're going to ask Kristen if the sound is heard equally in both ears or better on one side than the other.
Equally.
And she hears it equally, and that's correct. The patient should hear equal sounds in both ears. If the sound is lateralized, then we find out which side is better. Today we'll be examining the lymphatic system, and we're going to do that by palpating the superficial lymph nodes for size, mobility, edema, erythema, and red streaks. Superficial nodes that are accessible to palpation but not firm or large enough to be felt are common. A node fixed to surrounding tissues is cause for concern. The nodes that are easier to palpate are the superficial nodes in the neck. We're going to lightly palpate the entire neck. We're going to have the patient to slightly bend her head forward or to the side to palpate the nodes. Some of the nodes of the head that we will examine today is the occipital nodes, which is at the base of the skull, and also the post-auricular nodes, which are over the mastoid process, and the preauricular nodes, which are in front of the ear, and then the most common, the parotid or the tonsillar nodes, are just below the mandible. Moving down the neck, we're going to palpate the superficial cervical nodes. By standing behind the patient, I'm going to palpate along the anterior surface of the trapezius muscle and move slowly in a circular motion toward the neck. Next, we're going to examine the lymph nodes of the axilla. While holding the patient's arm, I'm going to lightly palpate in the axillary area for axillary nodes. Next, we're going to examine the inguinal lymph nodes, and for the comfort of my patient, I'm going to simulate palpating the inguinal nodes. The superior superficial inguinal nodes, or the femoral nodes, are close to the surface over the inguinal canals. The inferior superficial inguinal nodes lie deeper in the groin area. So these are the areas we would palpate. Next, we're going to assess the chest and lungs. We're going to inspect the chest, front and back, noting thoracic landmarks. We're looking at the chest for size and shape, symmetry, color, superficial venous patterns. Normal respirations in an adult is 12 to 20. The best way to evaluate or count respirations is at the same time you're counting your patient's pulse, is to watch the rise and fall of the chest. Rapid breathing may occur during hyperventilation. Respiration slower than 12 per minute may indicate neurological or electrolyte disturbance. We're also going to palpate the chest for symmetry. And we're going to palpate for tactile fremitus. And I'm going to have my patient repeat the word 99.
99. 99.
Decreased or absent fremitus may be caused by excess air in the lungs or may indicate emphysema or other conditions in the lung. Next, we're going to auscultate the chest with the stethoscope from apex to base, comparing sides for the following: intensity, pitch, duration, and quality of breath sounds. I'm going to have my patient take a deep breath in and out. Unexpected breath sounds like crackles, rhonchi, or wheezes can be noted. To auscultate the back, I'm going to have my patient to sit upright, arms folded in front, and head slightly bent. And we're going to use the same pattern that we used with the chest. We're going to start at the apex and work to the base. Next, we're going to assess the heart and blood vessels. We would inspect the precordium for apical pulse, pulsations, heaves, or lifts. We're going to palpate to detect apical pulse, thrills, heaves, or lifts. Next, we'll assess the heart and blood vessels. We would inspect the precordium for apical pulse, pulsation, heaves, or lifts. We would also palpate the precordium to detect apical pulses, thrills, heaves, or lifts. First, we would palpate the apex, and then the left sternal border, and then the base. Next, we're going to systemically auscultate each of the 5 areas while the patient breathes regularly and hold in her breath, where we can determine the rate, rhythm, S1, S2, and extra heart sounds. We're going to start with the aortic valve area, which is right intercostal space at the right sternal border. Second, we're going to listen to the pulmonic valve area. Third, we'll listen to second pulmonic area. And then fourth, we'll listen to the tricuspid area. And then lastly, we'll listen to the mitral or the apical area. To auscultate murmurs, we would have the patient in a sitting up and leaning forward slightly position and listen to all 5 of the areas. This is the best position to hear high-pitched murmurs with the stethoscope's diaphragm. Next, we will assess the blood vessels. We will palpate the arterial pulses for rate, rhythm, contour, and amplitude. We'll start with the carotid pulses in the neck, the brachial pulse in the arm, the radial pulse in the wrist, the femoral artery in the groin, the popliteal artery behind the knee, the dorsalis pedis pulse on the top of the foot, and the posterior tib. Next, we're going to auscultate
the carotid artery for bruits. And a bruit is a murmur or unexpected sound. We would listen over the carotid while we ask the patient to suspend breathing for a few heartbeats. Sounds heard over the neck include venous hums and carotid bruits. Also, in assessing the heart and vascular system, you would measure the patient's blood pressure. If the patient is at risk for orthostatic hypotension, you would check the blood pressure sitting and also standing. Next, we will inspect the extremities for sufficiencies of arteries and veins through the following. We'll inspect the extremities for venous insufficiency, varicose veins, or edema. To assess for thrombosis, we will note any redness, thickening, or tenderness along the superficial veins. Together, these suggest thrombophlebitis. We will check the Homan sign by lifting the patient's leg and dorsiflexing the toes. And if the patient complains of pain in the calf area, this procedure is positive and the sign may indicate venous thrombosis. Also, to check for edema in the lower extremities, we would palpate over the bony prominence of the leg. A depression that does not rapidly refill and resume its original contour indicates orthostatic edema or pitting edema. Next, we're going to assess the musculoskeletal system. We're going to inspect the skeleton and extremities and compare for alignment, contour and symmetry, size, and gross deformity. We're going to have Kristen facing forward. This is the anterior view, and we're looking for alignment and contour and symmetry. We'll also have Kristen face backwards, and we're assessing for alignment, contour, symmetry, size, and gross deformity, and also the lateral view. Next, we'll have Kristen stand against the wall, and if all is in alignment, her occiput, her shoulders, her elbows, and the back of her heels should touch the wall. Next, we will inspect the skin and subcutaneous tissues over muscles and joints for color, number of skin folds, swelling, and masses. We will also inspect the muscles and compare contralateral sides for size, symmetry, and spasms. Next, we're going to test major joints for active and passive range of motion. I'm going to have the patient relax, and she's going to allow me to passively move her joints. During the passive range of motion, the muscle should have slight tension. Passive range of motion often exceeds active range of motion by 5 degrees. No crepitation or tenderness with movement should be apparent. Next, we're going to test major muscle groups for strength and compare contralateral sides. I'm going to have the patient contract a muscle, and then by flexing, she's going to resist as I pull away, and then also push against. We expect the muscle strength to be the same bilaterally with full resistance to opposition. Today we will assess the neurological system. We're going to test the cranial nerves, and we're going to check cranial nerves 1 through 12. We're going to start with cranial nerve number 1, the olfactory, which is the sense of smell. I'm going to have my patient to close her eyes, and I'm going to introduce 2 different smells to her. She's going to cover one of her nares, and I'm going to have her inhale deeply. And she's going to identify the smell.
Alcohol.
Okay, and then I'm going to have her cover the opposite nares and have her smell a different fragrance.
And it smells like vanilla.
Okay, and I would repeat this process several times, alternating from side to side with 2 or 3 odors, allowing a short rest period between to differentiate the odors. The patient should be able to perceive an odor on each side. The sense of smell may diminish with age. The loss of sense of smell or the inability to discriminate odors can be caused by trauma to the cribriform plate or by an olfactory tract lesion. Next, we will assess the cranial nerve 2, which is the optic nerve. The cranial nerve 2 tests for vision with the Snellen chart or Rosenbaum vision chart, which I checked during the eye assessment. But just for review, we would have the patient to cover one eye and read the smallest line she could on the chart.
P-E-L-I-G-R.
And then we would have her cover the opposite eye and read the next line.
B-I-H-Z-R-D.
Okay. And then also with the Rosenbaum, we would hand her a chart to read at about 14 inches from her face.
The weather is nice.
Next are cranial nerves 3, 4, and 6, which we will omit from this assessment because we assessed earlier in the eye assessment. We'll go to cranial nerve number 5, which is the trigeminal nerve. We're going to observe the patient's face for muscle atrophy, deviation of the jaw to one side, and fasciculations. We're going to have the patient to tightly clench her teeth as I palpate the muscles over the jaw, evaluating the tone. Muscle tone over the face should be symmetric without fasciculations. 3 divisions of the nerve are evaluated for sharp, dull, and light touch sensation. I'm going to have my patient to close her eyes. And I'm going to touch her face with an object, and she's going to tell me if it felt soft or sharp.
Soft.
I'm going to use a different object and run it over her face, and she's going to tell me if she felt soft or sharp.
Sharp.
Next, we're going to observe cranial nerve number 7, which is the facial nerve. Motor function is evaluated by a series of expressions. I'm going to have my patient to make several facial expressions. She's going to frown. That's a smile. She's going to smile. Show me your teeth. Wrinkle your forehead. Shut your eyes really tight. And open your eyes wide. We're going to have her purse her lips as if she's going to whistle. And then puff out your cheeks. I'm observing for tics, unusual facial movements, and asymmetry of expressions. Muscle weakness is evidenced by one side of the mouth drooping, a flat nasolabial fold, and a lower eyelid sagging. And she has none. Taste is a sensory function of cranial nerve number 5 and 9. So I will assess them together. This is the glossopharyngeal nerve. Next, to assess sensory nerves 5 and 9, we're going to introduce sweet, salty, sour, and bitter to my patient, and she's going to hold up the card to which taste she distinguished. We're going to have her stick her tongue out. Stick it way up. And on the lateral side of her tongue, on the tip,
Sweet. Oh, sorry.
okay, let's keep your tongue out. We're going to allow her to have a little sip of water to get that out of her mouth. We're going to introduce another. Salty. Okay. Take a sip of water. Thirdly, laterally on her tongue, just behind the last one. And then last, laterally, a little bit further back on her tongue. This is the last one. From the taste test, the patient should be able to identify each taste bilaterally if placed correctly on the tongue surface. Next, we will check cranial nerve 8, which is the acoustics. Hearing is evaluated with simple screening tests that I used earlier in assessing the ears. Using a tuning fork, we compared air conduction to bone conduction with the Rhine test, and we tested unilateral hearing with the Weber test by placing a vibrating tongues on the patient's head, and she was able to distinguish if she heard the sound unilaterally or bilaterally. Next, I will assess cranial nerve 9 along with cranial nerve 10 as well, because cranial nerve 9 also affects the nasopharyngeal sensation or the gag reflex and the muscle function of swallowing. I'm going to have my patient to open her mouth, and I'm going to sweep along the posterior nasopharyngeal to stimulate her gag reflex. Gag already. And then I'm going to have her swallow. Motor function is evaluated by inspecting soft palate symmetry. If the vagus or glossopharyngeal nerve is damaged and the palate fails to rise, the uvula will deviate from midline. I'm going to have the patient take a sip of water, and the patient should swallow easily. No water should pass through the nasal or the nasopharynx. Okay. Next is cranial nerve 11, or the spinal accessory nerve. We're going to test the trapezius muscle strength. I'm going to have my patient shrug her shoulders against resistance. And I'm also going to test the sternocleidoid mastoid muscle strength by having my patient turn her head to each side against resistance. Also, we're going to observe cranial nerve number 12, which is the hypoglossal nerve. We're going to inspect the patient's tongue while at rest in the mouth for symmetry, tremors, and atrophy. I'm going to have my patient stick her tongue out. Okay. Now I would check the tongue muscles for strength. I'm going to have my patient to put her tongue in her cheek and push against my finger. Any fasciculations, asymmetry, atrophy, or deviation from the midline is unexpected. Now that we've assessed cranial nerves 1 through 12, we're going to assess the patient's coordination and fine motor skills. With my patient seated, I'm going to have her take her hands and she's going to pat her knees, and she's going to alternate between the palm of the hands and the back of the hand. And she's going to do it rapidly, and she's going to increase. I'm observing my patient for involuntary movements such as tics or tremors. Okay. Now we're going to check for accuracy of movement. I'm going to have my patient, while she's sitting with her eyes open, she's going to take her index finger and touch the tip of her nose, and she's going to reach and touch my index finger. Okay. And then I'm going to move my finger Now we're going to do it with the other finger. If the patient consistently missed my finger, it may indicate cerebellar disease. Next, we're going to check my patient's equilibrium with the Romberg test. I'm going to have my patient stand with her feet together and eyes closed. A little bit of swaying is normal. Okay. Loss of balance is a positive Romberg sign that would indicate cerebellar ataxia, vestibular dysfunction, or sensory loss. Next, we will assess the cortical sensory functions. I'm going to have my patient close her eyes. I'm going to put an object in her hand, and she's going to feel and manipulate the object and identify the object.
Feels like a key.
I'm also going to have her hold her hand out, and I'm going to draw
an object in her hand, and she's going to tell me what it is.
An 8.
That's correct. An inability to recognize objects by touch suggests a parietal lobe lesion. Next, we will check superficial reflexes by doing the plantar reflex test. I'm going to hold my patient's leg, and with the end of the reflex hammer, I'm going to pull up her feet and across the ball of the foot. The patient should have plantar flexion of toes. The Babinski sign is present when there is a dorsal flexion of the great toe with or without fanning of other toes. Positive Babinski sign indicates pyramidal tract disease. Next, we're going to assess deep tendon reflexes. With my percussion hammer, I'm going to tap on her patella ligament just below the patella. Contraction of the quadricep muscles causes the extension of the lower leg. Lastly, we will assess meningeal signs. A stiff neck is a sign that may be associated with meningitis and intracranial hemorrhage. With the patient lying supine, I'm going to slip my hands under her head and raise her chin to her sternum slightly to assess for stiffness. Also to assess, I can place my hands under my patient's shoulder when the patient is in the supine position, and raising her shoulder slightly will help relax the neck, making the determination of true stiffness more accurate. The Brzezinski sign may also be present when stiffness is assessed. Involuntary flexion of hips and knees when flexing the neck is a positive sign and may indicate meningeal irritation. This concludes my abbreviated assessment of the systems, keeping in mind that a more thorough assessment would include more in-depth tests and procedures.